Hello, everyone. Welcome to an introduction to enhancing public and community engagement and research and analysis. Thank you so much for joining our spotlight session today. My name is Laura Ferrer-Legier, and I'm the Senior Manager of Public and Community Engagement, Knowledge Translation here at ICS, along with my team members who I'll introduce momentarily. So a few housekeeping notes before we get started and just as everyone rolls into the room. So a reminder that the sessions are live and are being recorded. All the video recordings of this session and all the sessions today will be available after the forum. And at the end of each of our presentations and at the end of the session today, we will have time for Q&A. So feel free to type your comments in the chat. We're in a Zoom room, so you can freely use that chat function. Also, when it is the designated Q&A time, please also feel free to use the raise hand function and ask a question verbally and unmute yourself. We really want this to be kind of a dynamic, interactive session and give you the opportunity to ask questions as well. So feel free to do that way as well. So here today, we are the Public and Community Engagement Knowledge Translation team. So myself, along with Sabella Yusuf Homanath and Elise Liang Sit, work to support scientists, trainees, and staff to capture and incorporate the values of Ontarians in ICES activities and research. Really, our goal as a team is to ensure that not only are we supporting internal staff and scientists to think critically about engagement, but we also want to ensure that we as an organization are considering ways to ensure the people behind the data are reflected in all the work that we do. And really the reason that you may be wondering, why do we use the term public and not patient? And really the term public is used because the data at ICS is not limited to one specific disease or condition. We really have data that represents all Ontarians and really want to acknowledge that the data comes from many different populations. So to expand on that a little bit, I wanted to talk about kind of the three different groups that research and analysis at ICS can touch. And it's important to think a little bit about the level of engagement and its impact. So first on this diagram that you can see is stakeholders and knowledge users, which really is about all people, organizations, or partners who are impacted by research. So this could be nonprofit agencies, this could be government, this could be advocacy organizations. Now, what really kind of gets into the meat of what our small team does is public and communities. And these are really people whose data you're using to do your research who may want to have a say in how their data are used. The term community engagement is used in an effort to acknowledge populations who should be meaningfully engaged when their data are included in a study, understanding that communities encompass many different identities and experiences, including intersecting identities. And you may also be wondering, why do we use the term community? So we use the term community to acknowledge populations of people who've historically been excluded from health research, maybe stigmatized, or even harmed as a result of the research findings, and often denied access and control of their data. Now, I do want to point out here that when it comes to research that uses Indigenous data or identifiers, engagement and partnership is required. For projects looking to use data that includes Indigenous identifiers, ICS has ongoing partnerships and data governance agreements with Indigenous organizations, and these really strive to assert and respect the principles of ownership, control, access, and protection, or OCAP. Community partnership or ownership is required for these projects, and when navigating this at ICS, we always direct folks to the Department of Indigenous Partnerships, Data and Analytics, who work very closely with Indigenous partnerships. And finally, on this diagram, last but not least, is patients. And patients are those with lived experience of a specific disease or condition whose data you're using. And obviously, patients do fall in all these other groups as well, but it's probably the most specific when you compare it to the other two groups that I've just described. So in moving ahead, I'm going to talk a little bit about how we fit into ICS's strategic plan. So public and community engagement is a key success factor of ICS's strategic plan. And as a steward of personal information, it's critical that our work reflects the values and perspectives of Ontarians across its diverse communities. So part of this is that we will continue to engage the public and communities in the design of research and analytics at ICS, seek their input to guide our strategic decision-making, and ensure we communicate effectively the results of our work to diverse audiences so that they can use these analytics to better improve the health services in their communities. Another thing I wanted to touch upon before we really get into the meat of our discussion today is a bit about engagement as a science. So oftentimes you may hear, engagement being more of anecdotal evidence, but the truth is it's really a science that's backed by evidence. And in terms of what we know to date, the first systematic review on patient and public involvement on health and social care research actually spanned 15 years, and impacts were reported at all stages of research. Now, this systematic review is already a few years old. It's from 2012, and there's been a lot more research and development since that time. Here in Canada, you may be familiar with the Strategy for Patient-Oriented Research, or SPORE, and their Evidence Alliance and SPORE support networks across the country support many different SPORE-related activities for researchers, decision makers, and other stakeholders. It's pretty safe to assume that at this point, public engagement and patient engagement leads to better research. But there's still much to learn about the methods and impact, which is very much part of the work that our team continues to support here at ICS. So in saying that, and this being a spotlight session, we really wanted to make this interactive and engage all of you today. So we actually want to make this session a little bit of a choose your own adventure. So we're going to direct you to a poll that's going to pop up shortly, and it'll allow you to pick 2 presentations that you want to hear from today. So you should be able to pick 2 choices that you're interested in, and I'll give you a brief snapshot of each just to help with your voting. And I do want to mention that the session that isn't presented today, all the slides will be available in the web app after the session. And also we'll have a handout of resources for all the content today, including those not presented. Now, the first option is an introduction to what community engagement is and why it's important, along with a very brief snapshot of the first 2 steps you should consider in your research project. The second option, we've been working on a plain language thesaurus to help scientists and staff better communicate research findings to the public and communities. So we'll provide some background on that work. And then finally, we've also recently completed an analysis project with our Public Advisory Council, and we'll share some lessons learned. So again, pick kind of your top 2, try not to pick all 3, pick only 2, or just pick 1 as well if it won't let you pick more than 1. And we'll give a minute to see how this is weighing out. So I see some votes coming in. Tough choice, I know, but just don't forget that all the content will be available after the session, so you won't miss out on anything. I'll give a couple more seconds as things come together. All right. See, there's about 12 responses in. So the last 10 seconds or so, folks wanted to still weigh in on what they're interested in hearing. Great. All right, so I'll stop it there. And in terms of how this ranked, it looks like the first presentation, so engaging in terms of the first steps to engage communities, that was chosen. And then it looks like the last choice was chosen as well. So the understanding integrated knowledge translation, kind of a case example from our ICS Public Advisory Council. So with that, it's going to be kind of option 1 and 3 that we'll talk through. And of course, we'll provide resources as well at the end for the plain language thesaurus that we didn't get to discuss today, but we will also hear from Sabella, who will be talking a little bit about that content at the very end, just to give you some information. All right. So with that, I think this first discussion is actually myself. So I will proceed and give you a little bit of information on an analysis project that we did with the ICS Public Advisory Council. So I want to talk a little bit about the current landscape. So there's a lot of exemplar ICS work in patient, public, and community engagement, but there still largely is a gap for how to do engagement with administrative health data. Often the public is unaware of their data stewardship and don't need to approve its use in the traditional sense. As we know, there's not always REBs. This administrative data, obviously, there's a lot of safeguards in place, and it can be often used if people aren't always aware of that. Sometimes there's also apprehension that public engagement will be time-consuming or very heavily resource-intensive, which may kind of deter scientists or research teams from kind of going down that path. But we do know that meaningful engagement can enhance research quality and really foster public trust for data research. So as I kind of get into some information on our ICS Public Advisory Council, I do want to direct you either after this presentation to take a look at the ICS website. We kind of have two key pages here. We have our Public Advisory Council page, which really will give you more information about our Public Advisory Council. And then we have our Public and Community Engagement page, which gives you kind of more of that background that I talked about at the beginning of the presentation and more insight into the work of our team. Too far, so apologies. So when it comes to some background on the ICS Public Advisory Council, there it goes. It was formed in 2019 to guide ICS on what matters most to Ontarians with their health data. Today, the PAC includes 15 members of the public from various linguistic, socioeconomic, and cultural communities. Once again, our website is on the bottom for you to kind of explore a little bit about our Public Advisory Council further. But really, I want to emphasize that to become a member of the Public Advisory Council, or you'll hear me use the acronym PAC, no past experience is required. We want to balance different factors across the group to ensure that we have space for many different voices to be reflected at the table. And we really are looking also to make sure we have diversity in geographic location across Ontario, age, gender identity, racial and cultural identity, as well as a health or research background. Some folks do come with that, but many of the members of our group do not. And really, it's not a requirement at the end of the day. We do want people to come wearing their public hat. So when it comes to the purpose, really, there's kind of four key things here to highlight. And this, even the kind of original purpose was shaped and co-designed by members of that first cohort. So really, it's to reflect the values and perspectives of Ontario's diverse communities, but also to contribute to the design of our research and analytic activities. Many individual scientists or researchers will bring their activities forward to the PAC. It's to provide input and guide ICS's strategic decision-making and ensure that we effectively communicate to the public. Now, on this next slide, I just want to highlight as well that our PAC operates on a staggered membership. So that means that every 3 members sign on for a 3-year term, but every 18 months we're re-recruiting. So this is just a brief snapshot of all the members, past and present, who've been involved in this work. As you can see, there's many different names here and a lot of past members that have been very instrumental to this. So giving acknowledgement to all their hard work. So as I was mentioning about kind of that purpose being originally crafted by the first cohort, also one of the original objectives of the first terms of reference was to participate in the creation of a research and analysis project. And this was kind of started with education and background provided to the group with topic and research selection beginning in 2021 to 2022. The analysis was ultimately completed in spring 2023, with products now under development to finally kind of share those process and results, which will be coming soon, we hope, by the end of this year. The other thing I wanted to mention was that the International Association for Public Participation, or the IIP2 framework, lists different, like a spectrum of ways that the kind of public or patients can be involved in your research. So to be considered kind of a true integrated knowledge translation project, we really want to provide the PAC with the highest level of influence on this project. And according to the IIP2 framework, that really kind of brings us to the empower. So really having the PAC kind of influence and shape the direction that we're going in. I also want to acknowledge that the funding for this project was provided by the Ministry of Health through their Applied Health Research Question Program. And this is basically applied health research question is posed by an organization or a group to obtain research and analytics that help inform planning, program development, and improve services for communities across Ontario. So the ARC program isn't just available to our PAC members. Obviously, this is a larger kind of program that's available to any organization outside of ICS and funded by the Ministry of Health. So the PAC, with the Applied Health Research Question Team program, and of course the Mental Health and Addictions team, who worked quite closely with the PAC, worked together to better understand the following questions. So they wanted to better understand, where did Ontarians seek services for mental health and addictions, and what were their reasons for visiting? Did mental health service use change over time? And does mental health service use differ depending on income or where people live? Now, we won't be diving into these results today. I'm going to talk a little bit about the process and the lessons learned from doing this collaborative project. But I will say there's a report that we're currently working on, and it will be released soon, which kind of details what we found from these findings. So in terms of the approaches we used, I want to kind of emphasize that these approaches were used concurrently throughout the process. It wasn't always linear. We very much kind of came back and forth between these approaches. So first and foremost, we provided training sessions on the data we have and some of the potential questions that can be asked using the data. Overall, some basic understanding on the process, understanding also that we aren't trying to make the public into researchers. We really want them to come wearing their public hat, but just making sure that they have a clear understanding of the process and how things work. That was really a key approach that we used. We also used a lot of shared and guided brainstorming, including idea generation sessions and open forums to ask questions and help generate new ideas, both in a large group discussion as well as smaller groups. All of the stages also involved a sense of consensus building, either live or after the meeting via kind of these online surveys. We tried to ensure that all concerns were addressed and that there was general agreement on the path forward. We closely followed the James Lind Alliance and modified Delphi approaches to kind of help with some of this consensus building. And lastly, but also happening throughout the process, was gathering informal feedback at all stages to allow us to pivot when we needed to and adjust to the needs of our group. For example, when we realized we needed to give more information, we were able to do that at a time that fit for the group and make sure that that helped prior to kind of their final decision making. The last thing I want to touch on was really the lessons we learned. And in brief, there's kind of 4 key things here I want to highlight. So we learned that we need to be transparent on what our data can and cannot do, but also flexible across the board. Whether that be flexibility in meeting times, space, allowing for more guided sessions, or really just understanding that reaching consensus does take time, and it did take us time. We want to come in quite rigid with our approach and have our set agendas, but at the end of the day, we realize that's a little bit of a downfall. You have to be kind of flexible in this work and willing to recognize when you need to shift. Having a dedicated team and resources, I will say, was crucial. There's lots of moving parts here, and things need to be facilitated. So ensuring that anything said in a meeting does not fall through the cracks by having dedicated note takers, folks to answer questions that were parked during meetings. These were all really important, not only just to help with our general day-to-day functioning with the group, but especially for a project like this. Sharing power was also a huge cornerstone of the project, really ensuring that there's space for public insight along every step of the way. And then the one thing we learned also was that the lack of continuity in the group, although necessary to the functionality of the PAC, sometimes was a disadvantage to the flow. So as I mentioned, every 18 months, we kind of re-recruit. So there's always an overlap of existing members with new members. So kind of in the middle of this project, when half of the PAC was new members midway through, new ideas were brought forward. Now, that's not a bad thing. And in retrospect, these new ideas, I think, kind of helped with the final results. But you do worry with that about whether we are honoring what the original group wanted at the specific point in time. And also to help address this, we did kind of want to stay in touch with the previous members, and we do still have previous members kind of working on some of our final products. Really, the bottom line here is that empowered engagement, in other words, creating space for the public or patients to make decisions in research and analysis, is definitely possible. So with that, I will leave a few moments if there was any questions on this piece, but I will say we'll also have time at the end for Q&A as well. So I'll just give a quick moment and see if anyone wanted to either raise their hand or type anything in the chat before we shift over to our next topic to chat about. Great. So I don't see anything yet, but feel free if you're still thinking about this presentation, start to type your message into the chat. We will get to it at the end. And now maybe we'll shift over and Elise will talk a little bit about community engagement, which also I think based on our poll was of interest to a lot of folks here today.
Sorry, Zoom's being really slow. There, I'm unmuted, right? Okay, thanks everyone for joining us. I'm really passionate about this topic, and it was really difficult to condense some of the things that that I wanted to say into this kind of short, rapid fire format. But I'll really just give you kind of a touch point on some first steps, and there will be lots of time for us to have discussion or questions after kind of the formal part of the presentation. So firstly, I guess wanting to ground ourselves in what we're talking about when we say community engagement, because as Laura was kind of sharing at the very beginning, community engagement, it's a version of public engagement, but for those of you who maybe have worked in or participated in the public engagement space in the past, you're all likely very familiar with the fact that kind of broad general efforts to uplift the public voice tend to reach mostly a cohort of usual suspects, and some other voices are less frequently heard in these broad public calls. So with community engagement, it's really about asking ourselves, who is the public in public engagement? And then who should it be, right? So of course it depends what's on the table, but if our goal is to advance health equity in a particular context, we need to recognize that the most relevant lived expertise is from folks who live with inequities in that context. So again, as Laura described earlier, we use the term community very, very broadly in this space. And what it's going to mean is going to be different kind of project to project or in different contexts, but we're using the term community very broadly in this presentation to kind of acknowledge folks who may live with inequities in various contexts, but of course, keeping in mind that no community is a monolith, and any given community is going to encompass diverse individuals with different intersecting identities and experiences. And important to keep in mind too, that community engagement may or may not be appropriate for every project. Conducting this work, it really can't be to check a box, because if it's not done meaningfully, it can really do more harm than good. And sometimes even when our intentions are good, we may not always realize at the onset how much budget and time and thoughtfulness it might take to engage communities appropriately. So if you're kind of on the fence and interested in this, maybe you haven't stepped into this way of working before, a couple questions you can ask yourself. One is, do you have the timeline to be able to take the time to really get to know people and establish genuine relationships? Are we, mentally prepared to put down our expert hats and recognize that we don't have all the answers, and respect that different types of expertise people might bring to the table are valid as well? And are we mentally prepared that the process of working together is going to be iterative and definitely won't be perfect and smooth and easy right away, if ever? And if you've got some no's there, it might mean that this is not the right time or the right project to fully engage communities. Exception being, again, as Laura mentioned, if your project is looking to use data that use Indigenous identifiers. So this isn't the focus of this talk, but in brief, ICS's partnerships strive to respect the uniqueness of those data in keeping with principles of Indigenous ownership and sovereignty of their own data. those communities have the right to give or withhold consent to access their data. So in those cases, if the appropriate steps and readiness to collaborate with communities is not there yet for your project, it's a sign that the project isn't ready to go forward at all yet, because that community partnership and ownership is required in that space. So again, if you're navigating that at ICS, please connect not with our team, but instead with the Department of Indigenous Partnerships, Data and Analytics, whom you may have heard from today already if you were in room 1 at 10 this morning. You can also hear from them right now if you jump over to their spotlight session going on, or feel free to check out the recording of their session later. But in terms of other equity deserving communities, other community data, this is kind of our team's domain, and engagement is not required at ICES, but that said, it does remain our team's goal as the science of public engagement continues to take shape. We want to prevent it from becoming yet another system with structural barriers that exclude voices from those equity deserving communities. We lead some of the community engagements that happen at the organizational level at ICS. So for example, racialized community voices were the first place that ICS looked for expertise when developing our guidance document and framework for anti-racist research. When it comes to the level of individual research projects, if project teams feel it might be the right time to engage communities, those folks can reach out to our team. We don't have the staff capacity to lead all of that project level work for the hundreds of projects that might come through ICS's doors. We don't have the staff capacity to lead all of that work in the same way that we lead the organizational level work, but we do try to offer support at the project level in that teams can consult with us at any time throughout their project lifecycle. So something to keep in mind. I see some familiar names on this call. If you're ICS affiliated and you're exploring this space and want to brainstorm about your project with us, please feel welcome to reach out to us by email at any time, and we'll set up a chat with you. We also provide training sessions to groups like this one from time to time, and we collate or tailor templates, guidelines, example work from your peers that may also be helpful reading or starting point for teams as well. So in the very brief time that we have together today, I want to give just a few snippets and teasers of first steps that we recommend for community engagement. Please keep in mind, there's no one-size-fits-all approach to community engagement, and it's really going to depend on which community you're talking about, the context of your project, and that's why we always encourage project teams to connect with us for personalized consultation and a more nuanced and tailored discussion. But I'll just walk through today a few prompts and resources that may be helpful starting points to be thoughtful about this, especially if you're newer to this way of working. So all of what I'm going to share comes from a community engagement guide that our team has recently tailored for the ICES context, modified from one originally developed at McMaster for community engagement and research kind of more broadly. So we've now adapted that for the context of health and administrative data research specifically. But if interested, you can review the original McMaster tool, links on the slide here, or it'll also be in a handout that we'll share with you all before you go today. And you can also read more about the many other sources that informed our guidance, which were key informant interviews with 27 community partners, a scoping review of the literature, and influenced, of course, as well by our own reflections from our experience leading this type of work. So link to kind of the full background on that, also in the slide here or in your handout. But as an overview, we can think of community engagement in these sort of 5 stages. So prepare, plan, connect, engage, and sustain. And in my experience, research teams who are getting ready to take their first steps towards engaging community tend to imagine and mentally jump right away into the connect and engage phases. And, it can be tempting to skip over some of this preparing and planning that we really recommend happen first. So going to focus our brief time in this session on just these 2 most typically neglected elements. First one being to prepare. And this is sort of our homework before we assume we're ready to connect with communities, where we really look ourselves in the mirror, discard outdated notions of being an unconnected observer of society, and instead get a little personal with ourselves as human beings and realize that we're part of society just as our patients are. So a few specific prompts you can, again, ask yourself. One is, how might the community that I want to work with view institutions like mine or researchers like me? Because we need to remember that data has been weaponized against communities many times over the years. So we really need to flip our narratives about our relationships with communities from framings that are inadvertently community blaming and are common still. Like, for example, you might hear, oh, patients are non-compliant, or communities don't trust us. For me, I think it's important to instead kind of reframe that with more of an internal locus of control to our own institutions. So, for example, what have we done? And we have done lots, right? To show communities that we are untrustworthy. Or, what do we continue to do, even unintentionally, to uphold power differentials, right? It's about the wrongs that we have done rather than seeing lack of trust as kind of a community attitude, if that makes sense. And with that in mind, the second reflection prompt to ask yourself is, how can you use your professional position to uplift different types of expertise that may not be given center stage by default in status quo health data research? So, for example, you might have it in your mind that you want to engage communities, but have you thought about how much of the decision-making power that you hold by default that you're willing to share? So the IAP2 framework that Laura shared earlier is a great tool for kind of conceptualizing a whole spectrum of how this can look, right? And at the lower decision-making power sharing end of the spectrum, you might be focused just on kind of disseminating your research findings out once your project is kind of already done. More in the middle of that spectrum, maybe you're inviting community to give input on a particular decision, but it might ultimately remain your choice or your professional team's choice of how to use that input. Or further toward more of the shared decision-making side, right? We have more collaboration and empowerment where a person with lived expertise is perhaps a co-PI with you, or maybe in format like the project Laura was describing, it could be them driving and leading the project and you just kind of carrying out their wishes, right? So again, community engagement is not going to be appropriate for every project, and there really is no one size fits all approach that's always best. Different degrees of power sharing may be better suited to different situations. So it's not to say that this end of the spectrum is always better, but the idea is to just get ourselves thinking. So are we keeping decision-making power for ourselves for community-informed reasons? Like, for example, they may have told us clearly what we need to do, and they may be too overburdened to have direct oversight. So maybe they want us to implement on their behalf. That's a good reason to do that from my point of view. On the other hand, sometimes I think we make the decision to act on their behalf by default without actually considering any alternative ways of working and their respective pros and cons. So it's just kind of a prompt to touch base with yourself and see, am I making this decision by default, or have I actually considered some alternatives? And in addition to engaging community members, I think we're also realizing more and more in the health equity space that effective upstream solutions often involve collaboration outside the health sector. So if you're someone with a very clinical background, like myself, I'm included in this group, a clinical epidemiologist, a healthcare provider, folks with these sorts of backgrounds, you may want to consider inviting expertise from a collaborator in social epidemiology, sociology, social policy, etc., to bring the lens of their professional background to the work, which may differ from yours in ways that it's hard to anticipate until you hear it. And we have to keep in mind as well that the lenses we bring to our work are more than just our professional lenses. So reflection prompt number 3 for you today is to consider your intersecting identities and your experiences as a human being in relation to systems of power and privilege. They say that fish don't know that they swim in water, right? Because all they've ever experienced is water. To them, that's just kind of what the world is. And what this gets at is that we all have biases. We all have biases that we're unconscious of, shaped by how we've experienced the world. And a false consensus effect is very well documented, where we tend to assume that our beliefs and experiences are shared by others. So for me, for example, I'm a cisgender person and I don't so much think or worry about what the pitch of my voice sounds like all day long when I'm at work. And I was totally blind to the fact that that could be someone else's reality day in and day out until I heard about that from someone with lived experience as a transgender person. And these sorts of unconscious biases can really influence our work with data because we need to remember that as clean and neat as we try to make our analyses, they're really meant to represent human experience, and human choices do happen at every step of the analysis. So again, in the project Laura was describing, we were looking to measure use of primary care in Ontario. My first thought might be to check out the OHIP claims database to identify visits to family physicians and general practitioners, because that's the first place that kind of comes up when we talk about primary care in our own training and in kind of professional spheres and the verbiage associated with that, right? And it also happens to be my lived experience of seeking primary care myself. So what can happen is I might equate those two things, primary care and family doctor, as being almost one and the same without even stopping to think about it or realize that I'm making that assumption. And maybe it takes someone with a different lived experience to say, hey, I've never had a family doctor in my life. I always stop in at the community health center. Or maybe they say, there are no family doctors in my town. Everyone has to go trek to the nearest ER if we really need something. And these sorts of perspectives can really shape the decisions we make about what variables to include and how to proxy certain ideas like primary care, for example. So I hope you get the sense that this is a big topic, this sort of self-reflexivity. But these are just a couple of primers, prompts to get you started. And in the handout, there are also a couple more really fundamental background or resources that may also just start to help get you thinking about defaults and lenses and assumptions. Okay, so let's now say we've done some work and self-reflection in private in the prepare stage. The next step is to plan. And this is where we actually start to assess the specific situation. A key element that underpins everything else is determining who you want to engage and why. Essentially, how are you defining the community in community engagement for your specific context? What I've seen sometimes is that the temptation might be to go to folks who are adjacent to community. So for example, our community health center staff, rather than the center clientele themselves. And again, there's no one right answer or one size fits all approach to community engagement, but it can be really worthwhile to zoom in on that why piece to make sure that our decision around the who considers the pros and cons of various approaches rather than being a result of default thinking. So for example, maybe you just don't have the budget resources you would need to be able to appropriately compensate a large, diverse group of community partners at a living wage for extended time contributions. Or maybe you don't have the staff capacity on your project team to appropriately meet those folks barrier-free in the spaces where they are. But maybe you do already have a partnership with some of the leadership and decision makers at the community health center, and you know that having the voices of those staff is feasible for your immediate project and at least closer to community than you yourself. So maybe you decide to start there, and then who knows, maybe the following year, one of those staff partners might be able to connect you with a handful of patient advocates that they work with at that time later down the road. So sometimes, we have to start somewhere and let more relationships blossom organically. But just something to think about. And especially in cases where we're engaging with community members directly, we need to think critically about time needed to build relationships, which really cannot be overstated. I've found it helpful to get involved in, grassroots organizations led by the community themselves and just volunteer your time in whatever projects they're leading on their end that need some extra human resource. I'm talking about just broad general volunteer calls that they're putting out for, it tends to be less skilled sorts of roles, right? And by kind of participating in this way, you start to get to know people. They start to get to know you as a person. maybe including professional backgrounds that are part of your person. And sometimes areas of collaboration where the community may want to leverage more of your professional sphere of expertise can bubble up naturally. In other cases, sometimes we reach out to those community organizations, or we put out an open call for community members in a more structured way where we're already wearing our professional hats. Maybe we have some form of a grant or a project plan already. That can be kind of a common or like more efficient route to get there. But even when that's the case, I encourage you to consider the areas that could be co-designed within that, and how that aspect of working together can help to lessen power differentials. And if a community member maybe gets connected with you through an ask you've put out for this sort of pre-formed project, try to reframe your view of that person from being a research participant to really being a research partner. Develop a relationship with them as a human being. Take an interest in their interests outside the project, and be open to propositions outside the scope of the immediate project that they might bring to you, just as you would with an academic partner or collaborator you are working with. So I could go on at length about the next 3 stages too, but I'm really hearing from project teams in our kind of data space that these first steps and knowing where to even start can be the intimidating part right now if folks haven't worked in this way before. So, if that's you, and if you're going to only remember one thing from my introduction to this topic today, I think that the most important thing is that mental shift I mentioned at the beginning of our time together, where it's uncomfortable to accept that processes of relationship building and working with communities are going to be iterative. And there will be times where we're going to make mistakes, we're going to make missteps, despite our best intentions. And speaking myself as a person who has, like all of us, I think, made mistakes and overlooked things and had many blind spots pointed out to me, my experience has been that if you're coming from a genuine place of really trying to actively listen, right? We want to set aside any defensiveness that we might instinctively have about our own behavior or the behavior of institutions, and try instead to really actively listen, right? And from our hearts, respect people and their lived expertise. If we kind of come from that frame of mind, my experience has been that that sort of does come through even when we make missteps, and you'll sort of develop a bit of a trust bank with the community members you work with, where they'll forgive you and graciously correct you for your mistakes. Not that that's ideal, of course, and I think we can mitigate that with some of our own homework in the preparation stage, but decision paralysis that leads us to do nothing at all, I would say that's a greater risk. So on that hopefully encouraging note, I'll close it there and see if anyone wants to discuss or has questions.
Great, thank you so much, Elise. And I already see there is a question from the last session that I will come back to momentarily, and I'll give folks a minute to kind of mull over what Elise just discussed and think about some questions for the chat. And don't forget also, feel free to unmute and ask us verbally. That's okay, we're in a Zoom session. While we wait on that, and I will come back to that question in the chat, I just wanted to quickly share my screen. As I mentioned, we're going to share all the slides from today, including the presentation we didn't hear from Sabella. And I'm going to briefly share the handout as well, the list of all the resources from each of our session. And I just want to give Sabella a quick minute to walk us through her pieces on the handout, just so they make a little bit of sense, as we didn't hear that one off the bat. So let me quickly share that handout so you can take a look.
Actually, Laura, do you mind sharing slide 20 on the, I think it's still, actually,
Sure.
That's fine. I'll go through. I'm sorry, everyone. Hopefully we get to meet again and we can go through some of the work that we've been doing on the plain language thesaurus. And in keeping with the spirit of the entire day around being in an organization that's doing this very, very focused work on big data and administrative data, our main role has been to try to tailor things and take all those great resources that is available for knowledge translation, for public engagement, and tailor it and make it very useful for our scientists and staff so that they're, to improve and enhance their work, and to also to improve the work that they do with communities already within the organization. So the plain language thesaurus is within that spirit. There are many that exist generically online, or what we try to do here was to take that and tailor it for the use in specific research that we do here at ICES. And what I wanted to point you to was just some of the resources that we use to create that thesaurus. So some of the plain language checklists available from SickKids. The Center for Disease Prevention has many different plain language thesauruses and resources, and general guides to communicate in plain language. And then there's a great book in Making Data Talk. We used all of these plus more to create the thesaurus itself. Laura, do you mind sharing the slide 20 on the slides, or at least, sorry, I think you have the slides.
Let me circle to that. Do you want to, Laura, do you want to circle back to your question from?
For sure. And actually, there was a quick question. Are we going to get the links or documents? And yes, absolutely. Everything that Sibel is going through right now, along with a whole list of other resources, will be available. It'll be shared in the chat as well. It'll be in the web app. If you go back to the web app after this session, you'll get the link to the handout as well as the slide deck.
Sabella, is this what you wanted?
Yes, thank you so much. And just to reiterate what Laura said, you will have the slides with all of this information, but I just wanted to let you know that we are doing our usability testing on the thesaurus right now. We've just finished our first round and are about to take that feedback, update the thesaurus, expand it a little bit more, and we will be doing some more usability testing. If you're doing research and you would like to be a part and also have access to the thesaurus itself, please feel free to contact me or anyone on this call. Again, our contact is here and on the handout, so looking forward to hearing from you if you'd like to be a part of this. So I'll hand it over back to you, Laura.
Great. So I will get to this question in the chat first, and then I do see there's someone with their hand raised, so I see you. We will come to your question momentarily as well. So just kind of going back to one question related to the Public Advisory Council Research and Analysis project that we did. So the question was, regarding power sharing, are there specific strategies you employ to facilitate making space? And that's such a great question. And I think, again, this could look different in any project you do. But I'll just tell you a little bit of what we did for this specific project. So there's kind of two main things that came to my mind. And number one, I'll actually also, Sabella, you may want to speak about this since you were heavily involved in this piece. But from the onset of kind of thinking about doing a project like this, there was a values generation exercise with the Public Advisory Council, where basically before we even got into, thinking about the topic area, thinking about the question, we wanted them to generate a list of values that were actually important to them as a group. So they came up with kind of this collective list, which it is discussed as well in one of the resources in the handout you can access. But just to help them kind of really guide this work. So Sabella, I don't know if you wanted to add on that because you were very much involved in there during that time.
Sure, thanks, Laura. Yes, the values exercise was very pertinent to this project, and following up from that, in terms of sharing power, I think the next best thing was also the brainstorming sessions with the team. So you have two sets of stakeholders coming from two different lenses. You have your public lens, you have your very technical lens, and we had many small brainstorming sessions and our version of a feasibility assessment, where the public, everything they wanted to know with regards to the values, so whether it be equity, whether it be access to health services, they were able to ask specific questions to our technical team, and the technical team, they were able to assess those questions based on several criteria that we developed to say, okay, what can be done within the limitations and within the parameters of ICES. That created that shared knowledge. So when we did come to consensus, our Public Advisory Council members, they had all of the knowledge necessary needed to make decisions on their project. They didn't feel like they were left out of anything. They were equipped with that knowledge, they were equipped with that decision-making skills. So whatever direction they wanted to go, they had all of those tools available. So I think those would be my top two recommendations in creating that power sharing within your research space.
To build on that,
Yeah,
if I
thank you.
may, I
Oh,
think,
go ahead.
you know, what we were learning when we got to kind of the analysis step, which may be of interest to folks on this call, given the work that ICS does and our other HDRN colleagues across Canada. I think what was a bit novel about this project was the fact that it was public-led and involving, you know, this big administrative data sets. I think this sort of way of working, public empowerment, public-led research, has taken hold a lot more in qualitative research or in smaller quantitative contexts. But when we were kind of digging on, you know, how are we going to do this in the actual analysis and interpretation piece, we didn't find a lot in the literature to really guide us. But our experience was that giving folks the opportunity to really look at the analysis and the preliminary steps, you know, we were blown away by all of the kind of blind spots to us that were pointed out, or like the value add from the public perspective at that stage. And so I would add, I guess, how this relates to the question is, I think questioning where we think public can and can't or should and shouldn't be included, and instead really embedding their voices all the way along, including and especially in our big administrative data research analysis undertakings, was really key as well.
Yeah, thank you both so much. And really just to close it, I would say the last thing that I found also helpful was senior leadership is always there at our ICS Public Advisory Council. So Dr. Michael Schul and Dr. Astrid Gutman, who are our CEO and Chief Science Officer, do attend these meetings as much as possible, but not to attend in the sense of interjecting or providing insight. It's more to sit back and listen and be there for questions as well if our PAC members have concerns that they want to bring up directly to senior leadership. So I think that's also just understanding, you know, the roles that we need to take in these meetings and as we kind of work to develop these questions as well. So I see another question came through the chat, but someone has their hand raised. Stephanie, feel free to unmute if you want to ask your question.
So actually, it is look. I'm using my wife's computer. I work as a community engagement officer at Ottawa Public Health, and primarily I'm a physician from DRC. So I have two questions regarding community engagement. One is the time consuming, because there are some topics which are, like, I'll give example for cancer screening. During my observation, it seemed to be a topic that is not attractive. And while we go to the community to promote cancer screening, it seemed to be the common response is, I want to wait. I don't want to open that box now. I prefer to wait years. So my change seems to be lengthy. So how do you, as the community engagement staff, stay inspired, maintain the relationship in the presence of a change which will take years or may not happen yeah, this was difficulty. And the second one, the first one, so again, for diseases, data, when we are encouraging community to again to get screened, we use data. So the survival after early treatment compared to another treatment, and there seems to be a fear coming with the data. People get afraid when you share the data. How do we share data in a way that doesn't frighten the audience? Yes.
For sure. Thanks for your question. I think there's a couple of, well, a lot we can unpack there. And happy to chat more offline as well if you want to reach out to us. Would be interested to hear more about the work that you're doing. Lawrence,
Yes,
Bella, please feel free to jump in as well.
Mm-hmm.
But I think, you know, in part, this comes back a bit to remembering that kind of community, like where community attitudes may come from, right? And I think communities have a lot of legitimate reasons to be fearful of data. And if we kind of come with that in mind, it can kind of help ground us, I guess, in a good way. In terms of like what we tangibly do, I think it comes back to the fact that community is not a monolith. And if you were trying to promote cancer screening within a certain community or a certain demographic, whether you're defining that by a geographic space, by kind of a socioeconomic circumstance, by racial or cultural identity, you know, however you're defining that, I would be willing to bet my life that there's going to be a range of attitudes within that community towards cancer screening, right? So on one end of the spectrum, there might be folks who, yeah, they're just really not about it. They don't see the value in that, like that's just not where they're coming from. There's going to be kind of folks in the middle, maybe they haven't heard much about it, but they don't have a strong feeling one way or the other. And there's going to be folks who are passionate about it and strongly believe in it, right? So where I think we can sometimes find success is rather than focusing on this end of the spectrum, within the community we're trying to engage, are there champions whose voices are within that community, right? Not ourselves as professionals, but voices within that community who themselves are really on board with that kind of shared goal already. So sometimes this could mean community organizations, or it could be our community health center staff even, who are kind of more closely tied to some of those patients. Very often, in the case of cancer, for example, it's someone who narrowly survived, or maybe whose family member did not survive. And, you know, maybe the narrative they've taken out of that is, oh, like if only we caught it earlier, right? And people do come with these really personal stories and experiences that they're really passionate about, that, you know, maybe they as community members can spread the message in a more meaningful way compared to us as professionals. So I'd say as much as we can like equally partner with those folks, it can really add a lot to our voices. Another piece here, especially in terms of like the longevity and things take time and sustaining relationships. And, you know, unfortunately, as like frontline engagement staff or frontline healthcare providers, this isn't always within our control. But as much as possible, if we can push the people we report to be a little bit more flexible in kind of this goal-oriented or like outcome-oriented lens, it gives us, as much as possible, if we can take actively listen to what the community might identify as their goal, rather than kind of coming in with what we think should happen and we know it's going to take years, right? Community might be able to identify some things that they're working towards that are, you know, maybe related, maybe some more related than others, wins that they can celebrate from their perspective, and kind of thinking of your organization's goal more as supporting community's goal rather than trying to onboard community onto our goal. In practice, it can be a subtle difference, but I think this kind of mindset can also be helpful and can kind of come through to people unconsciously as well.
Yeah, thank you so much, Elise. And I see we're getting close to time, so I'll just quickly wrap this up and get to our last question. But I also think the other important thing to emphasize is, you know, we know public and community engagement does take time. I think it's also important to recognize when a project may or may not lend itself to community engagement. And, you know, there's a lot more that we can say about, I won't even go into the details on that, but I think the important thing is, you know, if you do want to have a discussion further and dive into, you know, is my project appropriate? Because I think it's important also to think really critically about doing this and making sure that you have the resources in place, so it's not an afterthought. I think that's important to emphasize. With 2 minutes left, we have one last question I see come through the chat. Is, can you describe more about how the public was involved in leading the specific analysis? I think this is referring back to the Public Advisory Council. And what kinds of analysis did you do? How did the public lead it? Yeah, this is a great question. And again, it was tricky because even when we were setting out to do this, and again, Sabella was kind of involved from the onset, but we were looking at existing literature to see, you know, are there strategies we can think about? Like, how do we involve the public in data interpretation, especially with quantitative data? Because typically you see this a lot more with qualitative data. And I think, you know, this was very much a learning for us as we went. So the PAC very much chose the topic area. They decided on mental health, that they knew that was the topic area they wanted to land on. And we did use kind of consensus building approaches for that. And then they also helped to kind of lead the research questions that would be asked. So again, that was a lot of consensus building, talking about the data that we have, what we can and cannot answer, also what's already being done at ICS. So they really kind of led those first two steps. And they worked closely with the ARC team to talk about, okay, this is, they're going to focus on outpatient initially. And then something that actually came out of this was at our first meeting where we reviewed the results, the PAC determined there was a gap here. Like we hadn't looked at emergency department use of mental health services. We kind of only looked at outpatient visits, and that was leaving a little bit in a gap. And then again, it kind of, in terms of, dissemination, that was another key area. Like we reviewed these results with them and wanted to know, are these important to share publicly? Like, what are some avenues on where we should take these results now? So it was kind of a learn as we go. And I'll pause there, just hand it to Isabella to see if you had other thoughts being involved from the onset, but we can also definitely talk more in detail on this offline as well.
And we recently published a bit on this process, and that article is linked in your handout too, if you're interested in more of like the how.
Yep, I realize we're at time, so I'll just add very quickly, again, reiterating that the shared brainstorming, those feasibility that was embedded throughout. And then I have to allude to the work that our applied health, our ARC team did. Applied health research questions portfolio. Sorry, my brain just froze there. They worked during the analysis stage. They did a lot of work with going through the data, the background data, the analysis that they were going to do with regards to the questions, the gaps, depending on what the PAC wanted to answer. A lot to talk about and too little time. So we'd love to connect with you after to kind of walk you through the steps of that. But yes, just there was just a lot of information sharing and a lot of chance for questions with our council, so that they could ask their questions and they could get through those steps and get to decision making on the analysis project itself. So I'll hand it over back to you, Laura. I know we're 1 minute over time.
No, thank you so much. Thank you to everyone who asked your questions, who came to our session. It's really great to have a discussion about this. And as we mentioned, the handout's available in the chat, and feel free to reach out to us, public@ics.on.ca. Thank you also to Isabella and Elise for all your hard work in helping to put this together. And with that, we're going to take a lunch break until 1 p.m. So feel free to enter the lunch break rooms back on the platform. And then our keynote speaker will begin at 1 p.m. So thank you everyone again, and have a great rest of forum today.